to make sure we don't miss a single detail, we're going to follow this rapid clinical roadmap, starting with the patient's history, moving on to the physical examination, forming a clinical impression, performing our diagnostic workup, and then finalizing the surgical management. First up, Section 1, the patient's history, where we gather our initial clues. So, we've got a 34-year-old female patient presenting with a swelling right in the midline of her neck. Now, the moment you hear midline neck swelling, your mind should instantly jump straight to the thyroid. But look closely at the timeline here. She's had this for 4 whole years. It has an insidious onset, it's been gradually progressive, and it is completely painless. Honestly, this prolonged, quiet history is a massive clue right out of the gate. You know, sometimes what a patient doesn't have is just as important as what they do. Let's rapid fire through these essential negatives, because knowing what's absent helps us rule out widespread metastasis or airway compression. There are 0 pressure symptoms, no hoarseness, no dyspnea, no dysphagia, which means the trachea, esophagus, and recurrent laryngeal nerve are likely completely undisturbed. She has no signs of hypo or hypothyroidism. There are no other swellings like enlarged lymph nodes, no signs of metastasis like bone pain or sudden weight loss, and absolutely no family history of malignancy. Now, here's a fun little diagnostic curveball for you. When you're taking the personal and dietary history of a patient with a neck swelling, why on earth would we specifically care about her vegetable intake, and specifically cabbage? Well, it turns out that eating way too many vegetables from the brassica family, like cabbage, can actually be goitrogenic. Basically, these substances can disrupt the normal production of thyroid hormones and actively contribute to thyroid enlargement, otherwise known as a goiter. It's a fantastic little detail to tease out in a patient's history because it shows you really understand those sneaky environmental triggers. Moving right along to Section 2, the physical examination. Time for the real detective work. Okay, before we even think about touching that swelling, we have to follow some strict ground rules. Here's a quick story. A student once failed a clinical exam because they confidently presented a thyroid case, but completely missed that the patient's pulse was totally irregular. The patient was actually in atrial fibrillation from hyperthyroidism. You must check the vitals. Also, when checking for eye signs, make sure you stand at the exact same eye level as the patient. And when checking if the swelling moves with tongue protrusion, always support the patient's head with one hand so they don't accidentally move their whole neck and give you a false positive. So, when we do palpate, what do we feel? A firm 4 by 3 centimeter multinodular swelling sitting strictly on the right side of the midline. It moves with deglutition or swallowing, which confirms it's attached to the larynx and trachea. The trachea itself is dead central, and the carotid pulse is palpable. And this perfectly highlights a key finding. The rest of the thyroid, meaning the isthmus and the left lobe, are entirely normal and not palpable at all. Now, this part is absolutely crucial. It's amazing how a simple physical touch can rule out a major complication. Just by verifying that the lower limit of the swelling is palpable, we instantly know the mass is fully contained within the neck. If the lower limit were not palpable, well, that would indicate a retrosternal extension, meaning the goiter had actually grown downward into the chest cavity. We also need to check for Kucher's sign. It's this specific maneuver where you support the trachea with one hand and push the swelling with the other. If the swelling is compressing the trachea, this little push will trigger stridor or dyspnea, a choking sound or sudden shortness of breath. In our patient's case, this sign was gratefully negative. Her airway is totally clear. All right, Section 3, forming a clinical impression. Let's put all these puzzle pieces together. Taking all those meticulously gathered clues, we can confidently form our impression. We're looking at a 34-year-old lady with a multinodular goiter involving the right lobe of the thyroid. Because her vitals are normal and she has 0 signs of hyper or hypothyroidism, she's clinically euthyroid, meaning her thyroid function is entirely normal. She's in a normal sinus rhythm and completely without any compressive symptoms. And now for the million-dollar question, the one that literally dictates this patient's entire future. Based strictly on what we've seen so far during our clinical exam, are we looking at a benign or a malignant swelling? Well, the evidence is heavily stacked toward a benign diagnosis. Think about it. A long-standing 4-year history, super slow growth, a total lack of compressive symptoms, and the absolute absence of palpable lymph nodes in the neck. All of that points straight to a benign tumor. If it were malignant, we'd expect rapid growth, maybe some metastasis. Actually, scratch that. We'd definitely expect to feel enlarged rock-hard lymph nodes.
Which brings us to Section 4, the diagnostic workup, where we finally confirm our clinical suspicions.
Listen, you have got to follow this exact sequence. It's a classic trap if you don't. Step 1 is always the thyroid function test, or TFT, to chemically confirm the patient is indeed euthyroid. Only after that do we move to step 2, visualizing the neck with an ultrasound. And finally, step 3 is an ultrasound-guided fine needle aspiration cytology, or FNAC. You use the ultrasound to guide the needle to ensure you get the absolute best, most representative tissue sample rather than just going in blind. The ultrasound really does the heavy lifting here. It confirms our physical exam that the left lobe is perfectly normal. It checks the echogenicity, noting that hypoechoic or darker shadows are more likely to be malignant. It looks for increased vascularity, which is another big warning sign. And crucially, it checks the lymph nodes. A benign lymph node will have a preserved fatty hilum at its core and maintain its normal little kidney bean shape. Armed with that visual map from the ultrasound, the fine needle aspiration grabs exactly what we need. And the results? The tissue sample brings us to our final, definitive answer. The pathology confirms a benign colloid goiter restricted entirely to the right lobe. Finally, Section 5, surgical management, the absolute final step in our patient's journey. Since that left lobe is completely healthy, the correct procedure here is a hemithyroidectomy. This is the absolute minimum acceptable surgery for a thyroid swelling. It requires the complete removal of the affected lobe, in this case, the right lobe, plus the isthmus. You should never, ever just use the term lobectomy because leaving the isthmus behind is simply incorrect surgical practice. Hemithyroidectomy is the definitive answer. This